Get started. Chad and Carrie both went to the North Regional Respiratory Care Conference. Rochester this year. It jumps back and forth. It's the bi-state one with Wisconsin and Minnesota. So Chad is up first.
Yep. So Carrie and I attended the NRRCC prior to 12 years ago. The Minnesota and Wisconsin state groups used to do stuff on their own, and then they got together and decided for collaboration and I think pooling resources too. It's helped to bring in better speakers. So like Derek said, this year it was in Rochester. Next year it's in Wisconsin, and typically it's the Wisconsin Dells area. Usually the jungle-themed water park down there. But
Kalahari.
thank you, Kalahari. Next year it's Chula Vista, so we got to watch a video on Chula Vista over the lunch hour. All right. So I'm going to do a review on three of the speakers that I attended. The first one I went to, Shauna Strickland presented on burn injuries or thermal injuries. She is an instructor at the University of Missouri now in the RT program. Helps out in the College of Pharmacy, and she also is the Director of Education for the AARC, which is the National Respiratory Care Association, so the American Association for Respiratory Care. Prior to that, she worked in St. Louis in the Children's Hospital, and also another hospital in St. Louis, which was a trauma center and had a burn unit as well. So I know from working at a trauma center and then going through as a student and doing clinicals, I never had problems with the ER or any of the ICUs, but the burn units were the toughest units to go into, and it takes a special person to work with burn patients. So this is just burn data from 2015 from the American Burn Association. So approximately 486,000 burn injuries that required or received medical treatment, and then 40,000 hospitalizations related to burn injuries. Almost 3,300 deaths due to fire and or smoke inhalation, and 68% male and 32% female. Breaking down burns, so we all know there's the different degrees of burn, and then physicians and care providers label it by surface area too. So they have a calculation where they'll take a look at the skin that's been burned and figure out percent of body that it's been affected. So we have our first degree burns, which is our common superficial burns. Second degree burns, which is the epidermal and dermal layer. Third degree is where it gets really bad, so this is the epidermis and then the dermis are destroyed. Third degree burns, the vast majority of the time, require a skin graft, and it takes longer than 21 days to heal, and then there's usually associated problems with that. And then fourth degree burns, which are almost always fatal burns, depending on surface area, but obviously the deepest layers, muscles, tendons, and even bones. One thing to note for young pediatric patients, because the skin layers are not quite as thick as adults and older kids, their burns typically can be worse as far as the degrees of burn. Some of the burns that Shauna talked about that she's seen, so for her pediatric patients in inner city St. Louis, their typical pediatric burns were scalding burns, typically due to child abuse. And then they also had, they would see farm injury burns, so patients that would be stabilized at a local community hospital, and then they would transport into St. Louis, related farm injuries. And then also rural area. Missouri had a problem, like most states, a lot of problems with meth labs, so there would be meth lab explosions. So she said it was a lot of different types of burns that they would see. So you would have obviously the scalding burns, but the farm injury burns were typically due to flame. The meth lab explosions you have the explosion and the flame, but the worst part of that, she said, would be the chemicals that were released during the explosion. So one of the major ones would be ammonia during the explosion. And ammonia with the respiratory system, it will basically liquefy the tracheal mucosa, so that would lead to bad pulmonary edema issues and the like. So I'm just going to jump ahead here. A lot of the respiratory challenges that you get, so you get a lot of that increased edema. Secretions are a big problem. With some of the burns, if the air is super hot, you can have blistering of the airway, and then once that starts to heal, secondary down the road, you can have a lot of that secretion issue as well. Also an issue is, these patients deal with a lot of pain, so it's, depending on the burn area, it's hard to take a deep breath due to the pain. So you can have secondary issues. Pneumonias can set in, a lot of atelectasis. And then with facial burns, intubation can be a big issue as well. When the skin is burned, it automatically reacts and can tighten up. So a lot of times, intubating a patient with a facial burn sometimes isn't possible. So tracheostomies are pretty common for facial burns. And the like, we talked about hot gas inhalation injuries. Typically 20 to 30% of patients, upper airway obstruction is common with facial burns. Other issues and treatments for burn injuries. The biggest part for them, she said, is pain control. And then fluid resuscitation is huge initially and going forward, because burn shock, a big part of it is related to fluid loss as the body reacts. Corticosteroids, we talked about pain support. Nutritional support is huge. And antibiotics. Infection can be a big deal with burn patients. So I'm going to jump ahead here, and we're going to go into the next talk. Chris Bosley, and PHS actually sponsored this talk down at the NRRCC. Chris is a respiratory therapist down at Mayo. He is also the instructor for the pediatric portion at the Mayo RT school. So reviewing all of that with the RT students, and he's also one of the leads down there for Mayo on the RT end of things for their pediatric transports. So they do ground transport and fixed wing as well. So Chris reviewed the ABCs of pediatric airway infections. The illnesses he reviewed, so bronchiolitis, croup, epiglottitis, and then bacterial tracheitis. So bronchiolitis typically seen 2 years and under. Starts as an upper respiratory, and then it's followed by a lower respiratory infection. RSV is the most common cause of bronchiolitis, and typically seen in infants. They're one of the most common illnesses seen in infants. Jump ahead here on my notes. Treatment of bronchiolitis. We all know about Synagis. High-risk groups on bronchiolitis. We have our premature infants, infants with chronic lung disease, kiddos with congenital heart disease, and any immunocompromised patients. Typically 1 to 2% require hospitalization nationwide, and this is from a couple of years ago. It was estimated about 90,000 hospitalizations annually. Jumping ahead to croup. So croup is that inflammatory condition that affects the vocal cords and subglottic airway. I think folks probably have heard the audible sounds of a croup patient before, kind of like that seal-like barking cough. One thing to note between croup and epiglottitis, croup is typically usually a viral condition, and epiglottitis can be more of a bacterial issue where the treatment would be antibiotics. So Croups defined as a viral mediated inflammatory condition. It affects the vocal cords and the subglottic airway. Typical treatment for croup usually is cool aerosol. Oxygen can be used PRN. Fluid hydration is huge. And depending on how bad it is, airway management, sometimes you need intubation to be done. But a big part of it is just reducing agitation and kind of position of comfort for the kiddos, so you can decrease the inflammation. And then sometimes they do use corticosteroids as well. Kind of comparing croup and epiglottitis, I had mentioned croup is more of a viral issue. Epiglottitis is bacterial. With epiglottitis, it's definitely a rapid onset. Typically, you'll see a high fever that'll spike within the first 24 hours. Antibiotics are typically always needed with epiglottitis. And usually with epiglottitis, you will see more stridor when the patient is supine. And then this is just kind of a side x-ray of an enlarged epiglottitis with the patient. So with epiglottitis, it's usually more prevalent in the winter and spring months. Patients typically appear very anxious when they have it. It's usually more severe with younger kids, so patients kind of probably 2 years of age up until about 10, just because their airways are smaller. So when the epiglottitis is swelling, they obviously lose the ability to breathe appropriately. So at times it can be in an emergent situation. The organism typically found with epiglottitis is Haemophilus influenza type B, but researchers have found that the incidence has decreased with the appropriate vaccinations, so your Hib vaccine. So that's been seen. Other causes, some have been group A strep as well, but it's typically been the Haemophilus type B. I'm going to jump ahead another slide here. So this is kind of looking at from the top down. That's the swollen epiglottis right there. And then this is actually an endotracheal tube that they're passing through as they intubate the patient. So that polyurethane looking thing right there. Treatment on epiglottitis, usually in the ER, you definitely want to consult with anesthesia or ENT, depending on how urgent it is. Usually it will require like a size smaller on your endotracheal tube. Corticosteroids are usually used, and racemic epinephrine, whatever you can get to decrease airway swelling. And then antibiotics in use as well. And then our last airway infection covered is bacterial tracheitis. So that's defined as an acute invasive exudative bacterial infection of the trachea and upper airway. A lot of the symptoms are similar to our croup and epiglottitis. The one thing with this, usually you'll see it on the younger kids, and then it's treated with vancomycin. Chris had mentioned was the typical treatment on that. They will also see a spike in white blood cells, which makes sense, and a lot of airway secretions as well. All right, I am going to jump forward here. On the last day, I went to a talk on SMA. So Mary Stroth was there. She's a pediatric pulmonologist at the University of Wisconsin. We have a fair number of our SMA patients know or see Dr. Stroth for treatment. So she is down at the University of Wisconsin. So she talked on SMA, and we'll kind of break it down here. So the carrier rate for SMA is 1 in 50 people are a carrier. Incidence estimate is 1 in 6,000 or 1 to 10,000 live births. Dr. Stroth felt like it was closer to that 1 in 6,000 range. Diagnosis is by gene mutation testing, and it's the most common lethal disease of children 2 years and under. To have a kid with SMA, you have to have, so it's autosomal recessive, so each parent would need to carry a copy of the mutated gene, and then there's a high chance of their child having it. Clinical classification of SMA. So we have SMA type 1, so that age of onset is very early in life, 6 months and under. They are the kids that are unable to sit without support. Some folks will label them as the non-sitters as well, so type 1 are considered non-sitters. Without interventions, average age of death is 2 and under. So interventions for us, a lot of times, Dr. Schroth and other pulmonologists you'll see prescribed suction machines, oxygen to be used as needed, oximetry, cough assist devices are huge. Nocturnal non-invasive ventilation is big for these kids too, so this would be like your bilevel BiPAPs to mask. When those SMA type 1 kids get ill, a lot of times they'll end up using their non-invasive ventilation almost continuously. So portability is a big deal for them as well. And a lot of them use other secretion clearance devices as well, like the vest machines. SMA type 2, those are our sitters. Typically age of onset is 18 months and younger. And then, as you can see, without interventions, average age of death is 2nd or 3rd decade of life. And then type 3, more of our independent SMA patients, age of onset greater than 18 months, and they typically have a normal life expectancy. Some of the therapeutic strategies out there to treat SMA, there's some drug trials going on, but there's also some research facilities doing some genetic research, gene therapy. Nationwide Children's down in Ohio is doing gene therapy, working on gene therapy where they're replacing the SMN1 mutated gene with a normal gene. They're trying different vectors to see if they can get that to work. This screen up here, this slide is showing the various different research ideas. The ideas and/or drugs labeled or colored in yellow there, those are projects that are funded by the Cure SMA group, which is a national SMA group that pools their resources together. Some of the other genetic therapies going on, there's a gene activation study going on where they're trying to transcribe part of the SMN2 gene to stabilize. And then there is a splicing modulation study going on as well. So they're splicing in a good site to replace the mutated site. And then a couple of the drugs that are in use, and these are neuroprotection drugs. So there's Riluzole, which was originally developed for ALS treatment. So that's an existing drug out there that you're trying to use. And then Olesoxime, which is a new drug being developed by Roche Pharmaceuticals. And if you can see that one's up at the top up here, and they're actually in the phase 3 stage here, getting close to FDA approval on that one.
What's the gray versus orange?
Sorry?
Does the gray just mean no Cure SMA funding? Is that
Right, yep, just no Cure SMA funding. And some of them, there's the drugs in here too, but a lot of them are genetic therapy. There's a small molecule study that Roche is doing. Novartis has got another small molecule here, and then you have some of your Indiana universities trying that as well. You can see out on the early stages, so. I think that was it. Does anybody have questions?
Interesting though with those drug fundings for SMA.
Yeah.
I've sat through some of their board meetings because they'll be after their conferences oftentimes because those are orphan drugs. Have to vote on like, because they're putting up the cash, like what looks the best. There are some heated debates about
For
which
Cure
money.
SMA or
Yeah,
something?
it used to
Yeah.
be the Families of SMA, but now it's the Cure SMA group.
Yeah.
So they have maybe $5 million and they have to bet on which is going to be the best avenue to put in a pipeline, so.
Sure.
I'm surprised that ISIS one has gone so far. But anyway, it is interesting to, when you get
Yeah.
down to the actual money and the people that are just family members putting up the money, making these decisions.
Oh, that's who the board is? But you've got like Schroeth in there and
They
everything
do.
too, right? You've got
But-
pretty informed individuals.
But mostly it's family members that make the decision.
Wow.
Yeah, it's a big deal. And Dr. Schroeth had mentioned she's also, I mean, she does a lot of medical consulting with Cure SMA, so she's
She's
one of the
kind
big
of
ones
slowly
involved.
moving to spend more and more time with Cure SMA, that's her goal.
Yep.
All right, thank you, Jen. And Carrie from the same conference.
Side note from Chad's presentations, I think Bosley is going to be here on Monday, right? Chad?
Yeah, for the discharge. They were invited,
Carrie, did you go
Peter and
first?
Chris,
Is that
so.
okay?
That's fine.
Or what is it?
There's a group, the MSRC is working on a standardized discharge.
Hospital to home kind of
Hospital to home
transition.
type thing. So Bree volunteered PHS to host it. So it's been hosted at other locations.
So like Derek said, I attended the same conference. I've gone quite a bit over the 10 years I've been here, and both to the Wisconsin one and the Minnesota one. Over time, it seems like it starts to get a little redundant with some of the same talks about COPD and everything kind of focusing towards the adults, which, is not what we're focused on. So, but I did catch a few ones that were pretty interesting. Interventional pulmonology, that's actually a department at the U of M. This was presented by Dr. Felix Zamora and then Heidi Gibson, an RT that works in that department. And many of us know Heidi either through the RT community or have worked with her. But I kind of chose to talk about this one because a few years back, I can't remember which year it was, I watched her talk when they first were kind of starting this department at the U. And so it was interesting to see where the first couple of things that they were doing in that clinic and how they've expanded their offerings with the different kinds of bronchoscopies and cryotherapy and the thermoplasties, and I don't have to probably go through everyone individually. But the list has definitely expanded in the years since she started working there, and she's worked from the onset pretty closely with this Dr. Zamora. I did pick one of those therapies to kind of expand, and it's one we've talked about either in these or just in the community a lot, but there a lot of people have presented on the bronchial thermoplasty, but there was some updates that I wanted to kind of talk about. This is a treatment for asthma, so using the high temperatures on the smooth muscle in the lungs. And they've kind of refined it over the years. It was very, when Heidi first presented, it was kind of experimental, and they hadn't been doing. Now they're regularly doing this procedure on patients, and they've got their criteria. So you have to have the documented asthma. It has to be uncontrolled with medications and kind of specific with the steroids and the bronchodilators. And then the FEV values have to fall in, so they do some extensive diagnostic testing prior to that. And this one is, I think, a new one they added, non-smoker for a year and less than a 10-pack year history of a former smoker. So so they must have maybe had some bad experience that they kind of added that one in. And controlled exacerbating illnesses. So the rationale for this is, and this again is kind of redundant because we've gone over this before, but it's that thermal energy applied to the smooth muscle, and treated airways have the less ability for bronchoconstriction. So it's just working on that the interaction with the smooth muscle. She talked about their protocol now of the pre-treating with steroids, and then on the day of treatment, the steroids, post-treatment with steroids. So they're pretty specific about their protocol as they go through. And then it's actually done 3 different times, so they have recovery time. So they go in, have the procedure, then they go home for a few weeks and come back and do that 3 times. And then they can do it unconscious sedation. This is the one that I wanted to bring up because I don't think we've showed this slide in any Lunch and Learns before. That kind of really interested me. So it shows the different spots. I don't know if the pointer will work, but these little circles are all the points that they have to go in and touch. So it takes a long time because they go really slow as they're getting the probe down there, and then they have to systematically make sure they're hitting all those spots. So the doctor's doing the probe, and the RT is kind of managing and assisting him and making sure he gets all the spots. And many of you have probably seen these before, but for those who are not, that's what the machine looks like, and this is the actual probe. So it goes in, and then you squeeze the little actuator there, and that makes the probe expand so it can catch the airways and burn in there. So it doesn't look very comfortable to have that in your lungs. And that it's systematically advanced, like I said, in the airways of 3 millimeters or greater. So it's just kind of pushed in there, and then they expand it, do they have the controller, and they heat it up to 65 degrees Celsius. Wait a little bit, move it to the next spot. Okay. So any questions on that one? Is the next one right after it?
You said that,
Or 2.
sorry,
It's okay, you can't see.
you said that some people choose to do conscious sedation. Do people actually do that awake? Could you actually do awake for that? Or everybody does?
I think you'd have to because you'd gag, yeah.
You'd never-
I don't think you'd, no, yeah, they can be done under that. I think they do put people out as well, so, yeah. But no, I don't.
Okay.
The second one, Robbie and I both attended this one, RT role in the assessment of prevention of pressure ulcers, and this was presented by Megan Schultz. She was an RT manager at Children's. Since, a few weeks later, I think she's not there anymore. I think she went back to her other job, I've heard. So I think it was a clinic, maybe a sleep clinic or something like that, but yeah, Robbie said she's not there anymore, so. But she had a good presentation.
So she left Children's altogether?
I believe so,
Yeah.
yeah. And the reason Robbie and I went there is kind of illustrated in this picture. We see the masks break down in the home, and we were hoping to get some kind of insight on maybe what they're using that works better. But some background on it. In 2011, the Minnesota Hospital Association said 25% of all reportable pressure ulcers were device-related. I think most of us think of pressure ulcers and we think of like bed sores or things like that. So it was interesting to hear how many were respiratory or were device-related, and most of those, 25% in all patient populations, are cervical collars and respiratory devices. And then more particular to us, 50% of pediatric pressure ulcers are related to equipment and devices. So they say 45% is cervical collars, 33% would be respiratory. So the majority of those are going to be the CPAP and BiPAP masks, or the endotracheal tubes and the securement devices for those. Maybe some oximeter probes and stuff like that. But
Seen some trach collars too.
yep, trach collars, yes. And then 22% were rectal and G-tube kind of things, so which our nurses are definitely seeing. I focus obviously on the mask ones, but and it was interesting to see that we're running into obviously a lot of the same challenges, but their main challenges are lack of the hospital grade masks. So a lot of people don't know this. There's kind of a difference between the masks that we use and some of the ones they use in hospital, because they end up having to throw them away after each patient uses them. So they might be a little bit not as sturdy as the ones we have in home, and the products they're made out of are not maybe as comfortable or soft or cushioned and things like that. So that is obviously can cause some problems. The staff is very unfamiliar with sizing. The staff is a lot more diverse than in a smaller company like us, and so they can't really train everybody on the sizing. And then this is one that we had to do for a long time, adapting the adult equipment for pediatric uses. Over the last couple years, we started to get a lot more smaller masks that are designed specifically for peds, but for years we would have to do that same thing where we're taking the very small adult ones and putting them onto pediatrics. Or even, there's a couple different mask categories, like a nasal, which just covers the nose, versus a full face, which is covering nose and mouth. Often, either we had to or the hospital were using nasal masks for adults as a full face on peds to cover both the nose and mouth. So it doesn't sit right on the face and then can cause those pressure sores. And then also the staff was not trained on the infection control and cleaning. It makes a huge difference just to wipe the mask out once a day because of all those skin oils and stuff like that that are on it. Some solutions they came up with. So this is the part where me and Robbie got a little nervous because we're like, we came here to learn something, but then they said they get DME grade masks and they consulted PHS to tell them which ones to use. So we're like, maybe we're not going to learn anything. But it was interesting. So I'm not sure who they worked with. I'm assuming somebody from our department kind of told, and then they put a list of all the masks they use, and they're ones that we currently have. So, they have kind of gone away from those more disposable hospital-grade masks to try to use things like the Pixie or the Nani, which we are now using on the really little ones. They also did extensive staff training, both for RTs and nursing, on sizing and cleaning. A very common kind of old school method to make sure you don't have any leaks with a CPAP or BiPAP mask is just to pull it as tight as you can, so then you can't have it leak. But a lot of the newer masks are designed to, the tighter you pull them, the more leaks you cause because of the way they fit on the face. So they really wanted to get away from those practices, and then if it's too tight, you're causing pressure sores. And then having both RT and nursing staff work on making sure the masks are wiped out and cleaned regularly. And then they also implemented a 12-hour skin integrity assessment within their electronic charting system, so they could be checking that with any kind of respiratory devices. They did extensive chart auditing to ensure all those assessments were completed, which we're all very familiar here as clinicians with the audits. And they also developed some staff competencies for them. They developed a skin integrity team, and that team was made up of physicians, nurses, and RTs, and they automatically were assigned to assess any patients that were less than 29 weeks. And then if there's any sign that there's going to be skin issues, they would be called in to assess the other patients as well.
Carrie, how long does it take for a problem to creep up in this arena?
Could be overnight.
You could, yeah. It could be weeks, it could be within like 12 to 24 hours, yeah, so.
I think it's once it breaks, it just goes.
Gets bad fast.
Yeah.
The person's skin integrity, their sensitivity issues, and then what type of mask, what's the mask made of?
So these are some more of their solutions that they came up for that, and something that I would really like to work on implementing here as well is just being a lot more proactive to those skin issues versus playing catch up. Because a lot of times, especially in home, because we're not seeing the patients, we don't hear about the issue until the skin is actually breaking down. And then they still need to wear the mask, so we're trying to put the mask over something, a dressing of some sort or something like that to protect that skin, and the pressure's still on there and it's not healing. So they actually have gone to more proactive approach. The Cavalon No Sting Barrier wipes, they're using those proactively Monday, Wednesday, and Friday on the infants and peds. They started in both the NICU at St. Paul and Minneapolis, and I think they've moved on to the PICU and the CVCC now. So they're starting with that right away. And then if they start to see any redness or irritation, they're moving right to the Mepilex. And then hopefully that doesn't cause anything further from that, but they do have the Liquicell patches too, that if they have some more stuff. So all products we have, but.
Cosmic bankruptcy is what I would like to say.
Yes. Liquicell?
Mepilex.
Oh, Mepilex, okay, yes.
From 3M to Netflix. There are other foam dressings.
Absolutely, and this is just what they're using,
It's
but
a great product.
They're a hospital. They're a hospital, they can get paid for it.
definitely.
But
we don't carry-
The bottom of the line, or the most.
No, that's 3Ms.
But Kevlar's not cheap either.
We have one.
And that's not a dressing, it's a.
Well, it's just a
It's a
white.
It's a wipe.
But it's
But
not
the liquid
cheap.
cell, I've never seen that. We don't carry
I
that.
think we do.
We do.
We do?
Yeah.
It's not always covered.
Yeah.
How does it work? What is it?
It's got kind of like a cushiony gel in the inside, so it's like a pad.
Oh.
Yeah, yeah. So, and actually, Lisa Jensen in customer service is seeing about coverage for the Cavalon. I don't think that we would have to jump to all of these other dressings or the expense of them, but just seeing if that would be something that we could proactively use in the home, like they're doing at the hospital, so that we can prevent the stuff ahead of time if possible.
And one thing we do in the home that the hospital usually doesn't, just because of the length that we are seeing the patient, is we'll sometimes have 2 different masks. And
Absolutely.
switch back and forth, so it'll be a nasal, and then it'll, like prongs, and then it'll be over the nose and try and relieve some of that
Change
pressure.
pressure points every other day.
Yeah. So I talked about this. They are automatically doing that Monday, Wednesday, and Friday, and then they're going to the Mepilex if they do see the skin breakdown. I think that was it on that one. Yeah. So, any other questions about that one? And another one, if you like, I didn't actually, for a couple of reasons. One, I didn't get time to put it together. Another talk that I saw that I really liked was, what was it called? Severe Traumatic Brain Injuries. It was presented by a physician, John Atkinson. So if you go to the nrrcc.com, if anybody likes to look at pretty graphic pictures, it's another reason why I think the people who watched me look at it at my desk were like, I don't want to look at that, but it actually was like 160 slides, and it was a pretty good presentation about a lot of case studies with traumatic brain injuries from both being hit with something, falling, to penetrating wounds, and the difference in survivability versus, a clean injury of, they showed the one that we know about that we've seen before with the screwdriver in there, how that one was very survivable because they just pulled it out and it had the nice rounded clean edges versus he had one with a knife and jagged edges and stuff like that. He had some pictures of like a kid who had just fallen off his bike, and he presented very normally and then ended up later passing away. And when they opened up his skull, the very large hematoma that had formed in there, that had shown no external signs, and it was still even on the outside of the skull. So there was just a lot of different ththings, but I recommend going to that website or the NRRC, and then he would have been on the Tuesday presentations and kind of checking out the slides if you have time.
Hopefully before lunch.
Yes. I was looking at them, thinking about if I was going to put slides together, and Crystal ran away from my desk because she did not want to see them. So, very, very graphic and realistic pictures.
Thank you. All right, Mr. Wall, pediatric transplant. That was Rochester also?
That was Rochester also.
What's
yeah.
going on down there?
Lots going on.
All right, so this one was at Rochester too. And Teresa and Jody are both part of the transplant team down there, so this was about pediatric solid organ transplant. Before I get started on my slides, anybody have any idea when the first transplant was and what it was?
Ever?
Yeah, that was successful
In PEDS?
in pediatrics.
Oh, pediatrics? 70s.
62.
Heart.
Heart.
Yeah.
Kidney.
The lower
Lower.
50s, the liver in the 40s.
1954 kidney. So, and then the late 1960s was our liver, heart, and pancreas transplants that were successful. And then in the 1980s, the lung and the intestinal organ transplants. So 1966 was actually the kidney pancreas transplant. 1967, the liver. 1981 was the first heart-lung transplant. 1983 was a single lung transplant. And then 1988 was a double lung transplant. So just to give you a little background.
What were they considering successful, 5 years, or what was their, obviously?
Just, I mean,
Just
that
survival,
it
right?
took the survival. I mean, I guess I don't know exactly what they considered successful, but just that it was a successful transplant, at least initially. I don't know I didn't look and delve into like how long those patients survived or not, but those were our first successful transplants, so. All right, so this just kind of gives you a little bit of and we deal with a lot of transplants here, obviously, for our pediatric patients, and we get some out of Rochester, we get some out of the U here, we get some from Omaha sometimes, and there's many transplant centers throughout the country, but this just kind of gives you a little bit idea of the pediatric kidney transplant was. And the OPTN stands for Organ Procurement and Transplantation Network. So it just kind of gives you a little bit idea of what they're doing out there. This one is if you're matching the donor to the recipient, the RH factor does not need to match necessarily. But if you're the recipient, these are the only donors that can provide you with the transplant with those blood types. So just kind of gives you a little bit of an idea. So not everybody is an option for each recipient. And then cross-match results. So if you have a negative cross-match, you don't have any antibodies against the donor, which will be more successful. If you have positive cross-match, you do have antibodies. So again, it just kind of gives you an idea of what's going to happen with those transplant patients. So if it's a negative, it's pretty good, strong chance that you're going to be able to, that they won't reject. If you have positive results, there's weak, moderate, or strong chances for rejection. And then also, you get all the way up to the strong, it's an incompatible donor because of the antibody production that is there. Here's pair donation. If you're going to be pairing, so with blood incompatible, antibodies, age, and virus incompatibles, it just kind of gives you an idea of who would be able to be paired with who here. So not everybody can be paired, and they do a lot of live donations now. I was going to just, I think that's coming up. Yeah, that'll be coming up in a little bit. I'll tell you what the live donation is compared to the deceased donation.
So, sorry, can I ask?
Yeah.
Virus incompatible?
Yep.
Meaning
There's a variety of different types of virus incompatible, a lot of different types of viruses. I don't remember all exactly what they are right now off the bat, but where you would not be compatible as a donor. Or if you had those also as a recipient. So, you guys remember my nurses?
CMV.
Yeah, CMV, that's right. CMV, EBV, Epstein-Barr, and this, yep. So there's a few varieties out there. The peds liver recipient age, here's your actual kind of breakdown of their ages. If you're going to have a kidney rejection, here are some of the signs and symptoms of that rejection. As you're looking through those, the one thing to remember is that there are often no symptoms at all. And the only way that they will discover whether they're actually rejecting or not is by doing a biopsy. So just something to keep in mind, but otherwise those are some symptoms of kidney rejection. Acute liver rejection, here's some more signs of that also. Your elevated transaminases those are your liver enzymes, like your ALT and your AST. And again, there's no symptoms. So immunosuppression, to avoid rejection, they usually will immunosuppress them severely so that they won't, if there's any antibodies present from the donor, they're not going to go ahead and reject. So, but there's a balance between avoiding rejection versus proper growth, especially with our PEDS patients. They need to grow in order to meet their developmental milestones, and then also avoiding infection, because as you immunosuppress them, they're at a much higher risk, obviously, to have potentially life-threatening infections like sepsis. Let's see. And then as far as medication administration, we use immunosuppressive medications. Like all of the ones that we use for our transplant patients, this is a really, one thing that they really highlighted is they are never held, except in the cases of life-threatening infection, and then only with the approval of transplant team, not the primary provider. The transplant team always has to be contacted if a medication is going to be held at all for any reason. And they'll make the determination of whether it's to be held or not to be held. There is something called post-transplant lymphoproliferative disease, or PTLD. It can occur with any solid organ transplant recipient. The risk is highest when the immune suppression levels are high. So the first few months of post-transplant, after rejection treatment, et cetera, that's kind of when it's the highest risk. It's usually caused by EBV or Epstein-Barr virus, which is a real common virus that's also leads to mono. It manifests as lymphadenopathy, fever, pain from swollen nodes, and sometimes bloody stools. This can be a potentially life-threatening post-transplant complication. We've actually lost at least one patient that I know of to this. It was one of my patients actually that ended up with this post-transplant and died because of it. The treatment is to decrease immune suppression. As you do that, they might add rituximab or another chemotherapy to help decrease immune suppression. They're usually followed by hemonc-oncology. It can progress to lymphoma if not treated, and that's what my patient, that one went on to progress to lymphoma. And they follow the EBV viral load to measure the effectiveness of the treatment. But it's a very serious potential complication. So, you think that you get through the transplant, it's successful, it takes, and then this can happen weeks to months to even years into the post-transplant. So there's so many, and we've all seen them, all of the nurses that work here with our transplant patients, we've all seen some of those potential complications. So just because you get a successful transplant doesn't mean it's going to stay as a successful transplant, which is unfortunate, but let's see. And then, let's see. So let's talk a little bit about pediatric heart transplant, the big picture. So right now in the state of Minnesota, the U here does not have a physician that's doing heart transplants. They're all done only down in Rochester right now because that physician left. But I've heard rumor that there might be another physician that's coming to the U. So I'm not sure if he's or she has started yet or not. I've just kind of heard that out in the wings. But so the closest place for a heart transplant here in Minnesota right now is Rochester.
Do you know who it was at the U? Was it?
I think it was Dr. St. Louis.
Yeah.
Yes, and Dr. St. Louis left. So, but
They actually just got their transplant.
what did you say?
They actually just got their new transplant physician.
Did they?
Yep.
Okay,
We have
so.
one of our nurses that works on the CVICU.
Oh, so there isn't he or she, do you know? Or?
He, I believe,
Okay.
and unfortunately he does not touch anybody with a trach.
Oh, he does. So interesting because I was just at a care conference at the U for a trach patient that they're trying to decide if that patient is going to be a candidate for a heart transplant or not. And one of the places in the country that they recommended they send all the information to that takes more kind of like high risk candidates that are trached or vented or whatever is St. Louis. So St. Louis is the one place where they do a lot of those type of transplants. So. Okay, and this one was presented by Sonia Dahl, another member of the transplant team down there. I know we've talked to her quite a bit. So some contraindications of a heart transplant are just severe fixed elevated pulmonary vascular resistance, concern for post-transplant, right ventricular failure, active systemic infections, multi-organ system failure, multi-organ transplant. They're less than 1,800 grams for their weight. Major CNS abnormalities and lack of family support systems. You have to have good family support systems to have a successful transplant because of the post follow-up care, which is, I mean, you know, when you look at, you can go into a home and there's syringes and bottles and there's a ton of meds and they have to follow and be willing to do the aftercare, otherwise there's no point in doing a transplant. It's kind of a wasted transplant. So other reasons are ventilator assistance. So like you said, Steve, mechanical assist device like ECMO, balloon pump, less than 6 months of age with congenital or acquired heart disease with reactive pulmonary hypertension, high doses of multiple inotropes. So we do a lot of milrinone drips here. It's one of our inotropes. So if they're on really high doses of that, they may not be a candidate. And the life expectancy without the heart transplant of less than 14 days. So those are kind of reasons we wouldn't think of doing a heart transplant with some of those kiddos. Oh, sorry. You know what? These are the patients that are candidates. I'm sorry, I got screwed up. So this is status 1A. So in March, the status of heart transplant patients for those who are placed on a 1A, it's a top priority. Those are the ones that they're going to get the heart first. These are the reasons they might get it. When the status changed, it also changed. If you're going to be a status 1A patient now, you have to be hospitalized in order to get that heart. If you go home, you go to a status 1B. So this is kind of what falls into that category. You go into a status 1B. So in order to get the first heart available, you have to be a status 1A. And some of these people that are in 1A really need that heart desperately, but we might be treating them at home. Like we have one that just, well, two right now, but we had one that just went home, was hospitalized, was on a status 1A. She would be the first one to get the heart, but they wanted to go home. So they've gone home, so now she's at a status 1B, so she won't be the first one in line for a heart. So,
And they counsel them on that before they choose to go
yes,
home?
they're counseled on that very, yes, yep. Yeah. So anyways, but she's being treated successfully right now at home on a milrinone drip also. So, but she still needs a heart. So. And then a status 2, 7 or a hold. Status 2 is a candidate who does not meet the criteria for 1A or 1B. Status 7 is temporarily unsuitable to receive a thoracic organ transplant. And an internal hold is just on hold for line infection, removal, or immunization. So if they need immunizations or they've had a line infection and they've had it removed, they may not be a candidate because of potential for sepsis with them. Some clinical signs of graft rejection in transplants are just alterations in the basic cardiac rhythm. This is all related to heart. Increased resting heart rate, bradycardia, third heart sound, or arrhythmias and conduction changes. Signs of poor contractility, decreased function of echo, cool and mottled extremities, rales, and oliguria and diaphoresis are other signs. So here's some non-specific clinical signs. So these are all signs that we need to pay attention to when we're going out to the homes and seeing these transplant patients. We often, when we get a new transplant patient, we'll be going out to the home 3 times a week, sometimes for labs and assessments. Then as they stabilize, it might go down to twice a week and even once a week, but these are all signs and symptoms that we need to pay attention to. And sometimes they're very subtle. The severity of rejection, there's a grade 0, no acute rejection. And then grade 1 is a focal or a mild acute rejection. Those are the signs and symptoms. A grade 2 is a moderate acute rejection. And then you have a greater immune response. There's more cell damage. You increase or switch maintenance immunosuppressant medications. They do what we call kind of a steroid blue over 3 days, a lot of steroids over 3 days. And then stronger immunosuppressant medications sometimes come with that too. And then grade 3 is diffuse borderline severe acute rejection. So again, you get a greater immune system response and inflammation, swelling, hemorrhage, vasculitis can also be present, requires admission to the hospital. IV steroids and other anti-rejection medications may be added to their current regime that they have. The most common form of rejection is a cell-mediated rejection. The treatment depends upon the severity of the graft dysfunction. It's usually a 3-day pulse of high steroids, ensures other med levels are okay. They might add steroids plus another medication called ATG. And then if it's non-responsive, they consider another treatment called AMR. So how long will a new heart last? Well, 50% of infants survive with a transplanted heart until 20 years post-transplant. So it's actually, you know, when you think about that, 20 years is a long time.
Is that 20 years or more, or they?
No, up until 20 years.
20 years. Okay.
50% survive until 15 years post-transplant. 50% of teenagers will survive until 12 years post-transplant. So, you know, it's not a full life expectancy, but a lot of these kids have a lot of severe underlying heart dysfunction. So, long-term complications that we look at for these patients. So again, like I said, just because you get your new heart or your new organ doesn't mean you're going to not have complications. And we see this all the time. Our transplant patients are up and down, up and down, up and down, in and out of the hospital. So it's rejection, steroid effects, infections, neoplasma, the PTLD, which can be fatal, hypertension, renal insufficiency, hypercholesterolemia, grafted-related coronary artery disease. Some key points that they talked about is that it's appropriate option when all other therapies have failed, but they'll try other therapies first before they think about a heart transplant. It is not a cure. They will most likely need a second or a third transplant, so not just one. And the best outcomes when rejection, infection, and neoplasms are avoided. So you want to try to avoid all those to get the best outcome if at all possible. And that's it. Any questions?